assessment performed by devices. Really, we do not found any difference between the venous angioplasty and the sham in terms of disability. To give you an idea, this is the visual acuity contrast. The red points are the PTA point, the PTA patients, and the black are the sham. You may see that the improved were in favor of PTA, but not enough due to the low power of the study because we have a few subjects. Also worsened more in sham than in respect to PTA, but this was not enough power. And the same happens also for the other disability area. More interesting, the results at MRI, because the mean number of accumulated lesion at 1 year was not significantly different, but the freedom from new lesions, for example, combined lesions that are the primary outcome, were almost two-folds increased probability to be lesion-free after venous angioplasty, 63% for PTA, 49 for sham. And much more convincing were the number of T1 gadolinium enhancing lesion that is considered usually by neurologists a negative outcome, and the probability to be lesion-free from this kind of lesion were almost 3 times more probable in PTA, about 80% of people versus 55% in the sham. So I think that these results is very interesting because show that the decongestion made by the PTA reduce the probability and may modulate better this kind of inflammatory biomarker. Much more convincing is 12 months after the procedure, because the mean number of accumulated lesion were in favor of venous angioplasty. So we have 0.47 new lesion respect to 1.27. It is very interesting because 1.27 is exactly the natural history of plaque accumulation, and 0.47 is really different. Also, freedom from new lesion, combined lesion, the odds ratio was, the probability was 2.64 in favor of angioplasty, T2 lesion accumulation 2.75, and also the T1 gadolinium enhancing lesion 2.38. So there is a delayed positive effect of the angioplasty 6 months after the procedure. What happens if we merge the relapsing remitting with a secondary progressive population? This can be done, was not published, so this is the first time that I present this data today in Madrid. This can be done because the secondary progressive have the same disability range, the same disease duration, and the same age limit. It happens this: combined lesion is a primary outcome, and we may achieve this with a significant improved probability. You may see that the population PTA lesion-free is well apparent greater respect to the sham population. We made several errors in study design, but this happens when you trace for the first time a path. This is the bad news, not so new, is that balloon angioplasty is very safe, but the flow was restored only in 54% of the PTA arm. However, no adverse events or complication were caused by this procedure, and we may say that is certainly more safe than a single dose of aspirin. We know, thanks to our kind of other types of contribution from different um, researcher that the preoperative morphology affects the effectiveness of PTA in jugular, particularly when you should have external compression, hypoplasia on the left side, and longitudinal endoluminal defects. The PTA is not very effective. I show you in a moment why. If you should have a longitudinal, very long leaflet that usually is an immobile valve leaflet, when you inflate the balloon, you lift up the, the, the valve and you do not pierce it. So it's very difficult to obtain a flow restoration in this case. To the contrary, if you should have a short stack and symmetric leaflets, really, in that case, the PTA is very, very effective, safe and effective. Also, if you should have compression on behalf of the muscle of the neck, for example, one of the more frequent situation is depicted in that angiography is the compression on behalf of the omoioid muscle. This, of course, is not good for venous balloon angioplasty. We did also error in trial design because the sham procedure, the catheter put into the jugular vein, is not so sham because flow was restored in 37% of the sham arm because in case of teeny septa flaps, these were pierced by the catheter. And this subject had a flow improvement respect the bottom line. This was really fundamental error in trial design that we may maybe avoid in further trial. Also, we made errors because the range was arbitrary and was based on what happened in normal people and not in MS sufferers. This was done because disability measurement were never done before. However, the traditional expanded disability uh, the score was constant in both arms. For example, this is the visual acuity you show. This range is in normal people, but maybe in MS could be this, and certainly may change the result. The same for manual dexterity. If you put a different range of, uh, of clinical significance of a measurement, you may have more chance to have red points in the improvement line. What are the conclusion? Brave Dreams was an underpowered trial. In addition, there were some shortcomings that I summarized in my presentation in study design, including sham procedure, sometimes effective. However, the study provided important information that helped to bridge the gap between veins and brain. And if confirmed, also the study a high prevalence of chronic cerebrospinal venous insufficiency in a mass population in a double-blind fashion, confirmed by catheter venography. PTA was safe, but did not restore the flow in about half of the unselected cases serial. It cannot be recommended and indiscriminately applied to all MS patients. This is clear. The delayed effect of PTA on MRI biomarker 6 months after the procedure suggests that PTA may produce benefit for a subgroup of MS patients. And we are now doing further analysis and investigation to provide the ID of such a subgroup. So this is not a goodbye, like in Casablanca, between Humphrey Bogart and Ingrid Bergman, but is the the first space to continue this kind of research. And it's very interesting that yesterday was published on Nature a review regarding our paper, and there are some words very important. For example, completely different pathogenetic mechanism in neurologic disease are rarely discovered, and CCSVI represented a new hypothesis to attempt to explain the pathogenesis of MS, and also that the accumulated new knowledge can be used for future endeavors when scientifically warranted and justified. Thank you for your attention.
Any questions? No, your Bravia Dream study or registry. I remember you tell me is the very very complex patient. It's not the initial symptom of the pathology of multiple sclerosis.
Yes.
And this is the neurona is not regenerated. It's impossible.
Yes.
Why not to check in the initial symptom?
Yes. Yes, I think that this is a very good observation. And certainly this is a factor. The hypothesis is if there is the coexistence of not good outflow, not good brain drainage, you have less perfusion, so less oxygen available for neurons, and also a more slow CSF flow that ultimately means less clearance of aptans, of proteides with the so-called lymphatic system of the brain. So this is my hypothesis, and I think that this may help, especially people at onset, in my opinion, should be investigated also in the workup on behalf of neurologists, also for the brain circulation, and not only from a molecular point of view.
Do you remember Dr. Amerizo Sebastian from Argentina talk one Neuro IMC with the acute I don't remember very well. Is the acute false memory
Neuroinflammation, or
yes, after problem of the jugular vein. And you check in the same way when there's another pathology of, for example, of vascular dementia?
Yes, we now had a grant on behalf of the International Rotary Foundation to explore the so-called heart-brain axis. And we have developed a special instrument capable to show you the cardiac beat, the carotid inflow, and the jugular outflow with 30 seconds of video clip. And after this video clip is analyzed by physics, and we found a lot of new parameters describing the inflow and the outflow from the brain in a very simple and non-invasive way. And we now are looking for vascular dementia, because if you should have a not good draining system, when you have, for example, hypertension could be multiplied for 5-10 folds. And so really the mechanic shock on the capillary part of the brain is great. And maybe next year I will show something about this.
Okay, I think
Okay, dear colleagues, let me share with you my short presentation about endovascular treatment of aneurysm in the region of the artery fenestration. I came from St. Petersburg. This is northwest of Russia, and I'm absolutely happy to be here. And thanks to dear Louis, I came to do this with you. The aim of our study it was assess the frequency of occurrence and the result of endovascular treatment of aneurysm on the region of the artery fenestration. From 2013 till June 2017, we operated 7 patients, 2 male, 5 female. 8 operations were performed. 4 aneurysm was located on the basilar artery. One aneurysm was P1 segment fenestration, one aneurysm of MCA, and one aneurysm of ACOM. All patients underwent endovascular procedure, 4 coiling and 4 stent assisting coiling. Some papers, some publication prescribing about localization of the aneurysm, symmetrically, not symmetrically, wide or narrow neck. And the main important thing, this is a 3D morphology. Because of this complex, this whole complex not only connected with aneurysm, but also more important thing, this is fenestration, because of this is a really unusual and rare variant of anatomy. Wide neck in our series was 6 cases from 7. That's why we started preventively double disease-oriented therapy for 6 cases out of 7. Here I'd like to show you some cases where we found just fenestration, like here on A1, multiple fenestration of ACOM, really rare fenestration of M1, and also you can see here a blister-like aneurysm and vertebral artery fenestration. Talking about the anterior circulation, we found A1 fenestration and also a double canal of ACOM or just fenestration of ACOM, and it's fenestration in this because of this looks like a fenestra, like a window, as you see. And here the example of A1 fenestration is the aneurysm. This is just obtained case. This is our next case. And here also you can see a fenestration of the basilar artery without some lesion, and aneurysm are located on the MCA. So 3D analysis of anatomy, this is the key to success. Like here you can see fenestration of the basilar artery, you can see aneurysm, daughter aneurysm here, and previously this patient has a hemorrhage. And after this analysis, we started operation. And we found that the narrow neck is really here. After aneurysmography, we found that all the perforators are located a little bit far from the neck space, and here you can see a daughter aneurysm also. And after that, we just made a coiling of this aneurysm with good functional and neurological result. The other situation, ruptured aneurysm, acute period, and after CT angio, after 3D analysis, we found that this is not only a common aneurysm, we have also a fenestration. And doing coiling again. And after 2.5 years, you can see that fenestration really exist. Aneurysm are completely occluded, and the whole anatomy safe. More interesting case, this is P1 fenestration. You can see double canal of this artery, and upper canal involved with lots of perforators. but lower branch are absolutely free of perforators, and here we can use just coiling without balloons or stents because of this kind of anatomy. This is natural anastomosis itself. The second one, acute case, you can see below double sacs aneurysm, which are located from one white neck. And according to this white neck lesion, we use one stent and totally occluding all aneurysmal sac by coils with good functional and angiographical result again. Um, Unusual from unusual fenestration case. MCA cases previously was treated by our colleagues, and it was previously it was less than 1 centimeter aneurysm. But when we obtained this case, we found that aneurysma growth twice and completely destroyed complex of coils. And we decided that probably our colleagues was not so intensive and employed less coils than they needed. And after analysis of angio, we found that body of the aneurysm much wider comparing to the neck zone, and we using after microangiography, we're using just coiling, and everything looks very well and good for 1 year before we made a follow-up. And here you can see again destroyed complex of coils. You can see growing of aneurysm, and we need to do something more effective than only coil. Here we've been prepared by double plated therapy again, and using the double lumen balloon scepter, we employed Elvis Jr. and did stent plastic immediate to have absolutely good apposition of the wall of stent to the all the walls of here fenestration and short M1 and ICA also. And after that, we filled all the free space of aneurysm with coils, and now just waiting for follow-up. And the last but not least, by this meaning case, this is basilar artery fenestration again, and such an awful aneurysm. And this is an interesting case because of this is the only one aneurysm from the multiple lesions. But here, after 3D analysis, we found that all the branches are partially destroyed and involved into the neck, and we need to protect all the channel of fenestration and remodel the canals and occlude it by curls. So we decided to make parallel stenting. Uh, First step was employing the first step from the origin of pica left to the left vertebral artery. It was made. The second step was from the right osteum of pica to the right vertebral artery, and after just implantation of two stents, you see partially stagnation of the contrast in the aneurysmal sac. And after that, using a gelled catheter, we occluded all this space of aneurysm by coils. We've got initial and follow-up control with good neurological result, and with more or less long-term follow-up, which showed us absolutely a reconstructed, unusual fenestra anatomy and fully obliterated aneurysm. Finally, all the aneurysms were switched off from the blood flow. Modifying Rankin scale 0 were for all our patients when they discharged from the department. Just 0.66% of all aneurysms were aneurysms on the fenestration. And angiographic control was obtained in all the cases, and one patient after our follow-up control being underwent for the second procedure. with stent assisted coiling. In conclusion, stent seems the preferred option for assistance because of, in addition to supporting of the coils, it changed a little bit blood flow and uh, arterial wall recovery. The use of stents always has limitation. In case when the multiple perforating uh, sitting on the lead branch. In a case when U or C-shaped curves on the anatomy of main trunk and branches of the fenestration, and when diameter between main trunk and one of the branches more than 50%. In a situation when there is a migration of coils to non-dominant channel exist of fenestration, this is no problem if here is no perforators. In such situation, you should remember that fenestration this is a natural anastomosis and it doesn't lead to neurological deficit. And only then spocking of coils is the key to aneurysmal curing. Thank you for your attention. Muchas gracias, dear colleagues. Luis.
Do you have any tip, even you show the stent system is one of the tips to treat this kind of aneurysm, but and 3D imaging also is very important, but not always is possible to reach a very compact aneurysm with coil. How do you do? You have more support than usual in these cases, or just do the same approach that whatever kind of.
Talking about high density packing, we using from the feeling part more short and extra soft coils, and these coils will be more or less comfortable for packing because of it's not so thick as 3D coils, and it's safe enough if it's short more or less because of you will not so you will not to be worried how to pocket it inside, and when you feel that tension are growing, you can just finish in your short coil and stop. And this will be like a good test. If the tension are growing, you can stop because of the rupture of the aneurysm will be in such situation absolutely awful because of the rare and unusual anatomy, and maybe you are not so ready to rupture of such a aneurysm as in the standard case. Thank you.
Okay, my friend.
Thank
Thank
you.
you very much. Thank you very much.